Okay, we can start the today's event. A very warm welcome to all of you on our World MS Day campaign. I want to welcome all our registered members, chairpersons, secretaries from 9 chapters, our guest speakers, senior leadership, volunteers, and friends. I welcome you all to the webinar on rehabilitation strategies in multiple sclerosis. Today, we have experts with us as a guest speaker. We have Dr. Joy, Dr. Ashish Contractor, Dr. Meruna Bose, and Dr. Gayatri. Thank you all for taking out time from your busy schedule for this event. Now, I would like to invite Ms. Anjali Vyas to give a short intro about the World MS Day. Over to you, Anjali.
Hello, good evening, people. बहुत गर्मी है. I know you're feeling extremely hot. It's summer, I understand. But that's why we are here, right? To beat the heat and celebrate the World MS Day. So we are kickstarting our campaign for the World MS Day, which is called #MSConnections. So what is World MS Day really? So World MS Day was initiated in 2009 by MS International Federation, of which MS Society of India is also a proud member. Since the past 2 years, we have been celebrating the theme #MSConnections, where we have done several events to connect with people, connect with oneself, connect with other disability organizations and whatnot. We did the mandala art through which we connected with ourselves. We also shared it with people across the globe, and you know what? Everybody enjoyed it. We also launched a caregiver booklet last year as a form of MS connections with our caregivers, because you know they should not be left behind. And in order to mark this celebration and the global MS movement to express solidarity, we also had this very beautiful event, and actually a series of events where we celebrated and expressed solidarity through the MS Heart. You see the sign language? MS Heart, right? So what I'm going to do now is I'm going to quickly share the very glimpse of what activities were done throughout the world in the month of May to celebrate the World MS Day in 2019 and 2020 and 2021 through a short video. Please hold on for a minute and enjoy this video.
I don't think we can hear the audio.
There is no audio, Anjali.
Oh, there's no audio?
No.
No, there isn't.
Right. I will still explain you guys what exactly happened in a glimpse. Just have a look. All right. So what did we actually see? You know, the entire world celebrated Dekha Na Aap Sabne. We had bike rallies. We had Global MS Choir where we sang together in unison with people across the world. There were over 100 countries that participated in the global movement of World MS Day. And India, being one of them, now continues to celebrate it with this great momentum and energy of all of these beautiful people present today. And of course, apart from us, outside our community as well. So I welcome you all and wish you all a very happy World MS Day. Keep the excitement alive, guys, and let's beat the heat. Bye-bye.
Thank you, Anjali. Now I would like to introduce our Honorable Vice President, Ms. Mamta Gupta. Mamta Gupta is a graduate in home science from Calcutta University. Mamta is a teacher by profession and a multi-talented personality. She joined the Hyderabad chapter in 2007. She could empathize with the MS person and their caregivers and was soon made the secretary, moving on to be chairperson during the year 2013 to 2019. And currently she is holding the position of Honorable National Vice President. I welcome you, Mamta ji. And now I will request Mamta ji to give an introduction about MSI. Over to you, Mamta ji.
Thank you, Javed. Hello, everyone. Namaste. Multiple Sclerosis Society of India, established in 1985, is the only patient welfare organization for MS in the country, with chapters in Bangalore, Chennai, Delhi, Mumbai, Hyderabad, Pune, Indore, and Trivandrum. MSSI is affiliated to MSIF, that is Multiple Sclerosis International Federation, which is a unique global network of MS organizations, people affected by MS, volunteers, and staff from around the world, whose vision is a world without MS. MSSI works to improve the quality of life of persons with MS, for which services are provided at national level and chapter level. Some of these are counseling, home nursing care, physiotherapy, scholarships, employment facilitations, aids and equipments, medical reimbursements in special cases, home visits to bedbound MS persons, free medical camps and annual health checks, seminars, webinars, symposiums, workshops, as well as recreational and cultural programs where MSPs are encouraged to showcase their talents. There's a youth MS group at national as well as chapter level. These members connect daily on WhatsApp, supporting and inspiring each other. MSSI's awareness work can be divided into two broad categories. First is the India MS Day, where MS awareness is made on the national platform. Each chapter organizes a similar event, for example, walks, rallies, exhibitions. Now, since 2 years, there have been national webinars to support this goal. The second one is World MS Day, where we work as per the guidelines set by MSIF. More than 49 member countries work on a single theme to create awareness of MS globally. In the last few years, MSSI has made its presence on the MSIF website by creating a series of yoga videos, specially designed for MS purpose, and publishing the Caregiver Guide. This guide and many other resources like fatigue and self-esteem have been translated into regional Indian languages to reach out to a wider audience. Now I'll share some advocacy efforts initiated by MSSI. A Reassess MS campaign was organized by MSSI in 2020 to advocate with multiple stakeholders and relevant government ministries to revise the current assessment guideline under RPWD Act 2016. The main focus was to bring to light the real life challenges faced by persons with MS across India when being assessed for disability certificate and the gaps that need to be addressed. These have been put together in a recommendation document with inputs from medical and scientific advisory committee comprising leading neurologists from across India and submitted to Ministry of Social Justice and Empowerment. MSSI has been advocating on the rights of MS persons, but unfortunately, it could reach only 2% of the estimated population of persons living with MS. In India, there is no mechanism of tracking and following up on data around MS. Realizing the need for a national registry for MS persons in India, MSSI ran a second campaign called Numbers Matter in 2021 to highlight to the government that absence of data causes barriers in access to affordable treatment, policy formulation, and research for MS. To support the same, MSI also started an online petition, Am I Counted? MSSI took the initiative to develop the India MS map, which was launched on 1st August 2021 and inaugurated by our guest speaker, Professor Dr. Kameshwar Prasad, neurologist, AIIMS, New Delhi, in the presence of Rachel King, lead MS Atlas, MSIF, UK. MSSI is making continuous efforts through its direct interventions and advocacy initiatives to bring the change in the life of MS persons. We believe soon we will have national registry for the persons in place, and there will be a better mechanism for assessment of MS persons, which would cover all eligible MSPs to avail government programs and schemes. Today, MSSI is a growing family with an everlasting bond that knows no boundaries. Thank you. Now, moving ahead, we are privileged to have Dr. Joy Desai with us today. Dr. Joy D. Desai is presently Director and Head, Department of Neurology at the Jaslok Hospital and Research Center, Mumbai. He is consultant neurologist at Sir H.N. Reliance Hospital, Mumbai. Also the DNB teacher for neurology at Jaslok Hospital, Mumbai. Dr. Joy Desai is a life member of IES, IEA, IAN, and a corresponding member, AES. He has many publications to his name, which include 28 peer-reviewed articles and 6 book chapters. He has also made numerous national and international presentations. His areas of interest are epilepsy, sleep, and neurodegeneration. Trekking and photography are his hobbies. We are grateful to Dr. Joy Desai for giving us his valuable time today, examining patients at our free medical camps and showing care and empathy towards MS cause. Over to Dr. Desai.
Thank you, Mamta, for your very kind and very gracious introduction. There are many accolades you have given me, and which perhaps I'm not sure I really deserve. So thank you, MSSI, for asking me to participate in today's webinar. And we all know that multiple sclerosis can certainly be a disorder that needs to be recognized as something that can take away function. And in most of our previous seminars, we have had luminaries in clinical neurology and pathophysiology and imaging talk about the symptoms and signs and the fallout of multiple sclerosis amongst the patients, and we've had people speak about therapies. Today, MSSI is going to embark on a very educative discussion on the value of rehabilitative strategies in helping patients with MS cope with what the disorder actually does. And we have a wonderful panel of speakers today. And there's Dr. Ashish Contractor, there's Dr. Meruna Bose, and there's Dr. Gayatri Hatiyangri. And we'll hear today from each one of them of modalities of lifestyle management and interventions aimed at coping with the disabling fallout of multiple sclerosis, enabling patients to live better, to be more functional, and perhaps having their spirits as strongly lively as Anjali Vyas, who was with us in the early half of the program. So it's my honor and privilege to be here today, and I shall not take up your time further. I would like to invite Dr. Ashish Contractor, and we should display Dr. Contractor's credentials. Dr. Ashish Contractor is my colleague at Sir Richard Reliance Hospital. He's the Director of Rehabilitation and Sports Medicine at the HN Reliance Foundation Hospital. He is an avid practitioner of the art of rehabilitation medicine, and he embodies the concept of using bodily resources to stay fit. And I can assure you that perhaps he's one of the most fittest consultants on the staff that we have at Sir HN and perhaps even in South Bombay. And today, Dr. Contractor will share his wisdom with all of us in tapping the resources of our own bodies to battle the fallout that MS can actually do. So it's my great pleasure to welcome Dr. Ashish Contractor. Ashish, I saw you here. You are there. So we are all waiting with bated breath to listen to you and empower our patients with MS to find the resources within themselves to overcome multiple sclerosis. Dr. Contractor.
Thank you so much. I hope you're able to see my cover slide.
Yes, we can.
Okay, thank you. So thank you for that kind introduction, Dr. Joyce. I know you are very fit as well, so I'm not sure about that fittest doctor comment you made, but thank you nonetheless. Always a pleasure to share the stage with you and interact with you. We haven't met for a long time or spent some time, which we should do, hopefully sometime next week when you're here. Thank you very much to Mrs. Sheila Chitnis for this invitation. She's such a lively person that whenever she calls, then it's just amazing to interact with her. And she's one of the few individuals whom I can never say the word no to. So thank you, madam, for inviting me. Thank you, Mrs. Michandani, Mrs. Gupta, Mamta Gupta, for organizing this. Thank you, Anjali, for the very lively introduction. So the talk today is around rehab and rehab strategies. This is a picture of our hospital. As you can see, we have the heritage building up front. This is a picture I've taken, I think, about 2 or 3 years ago, and what we call the tower building in the background. And the entire 3rd floor, where the top floor of this heritage building is our rehab center, where we look at rehab for all medical conditions, not just neurology. We do neurology, we do cardiac, pulmonary, cancer, orthopedic, we do all of those. And really the presentation today, I got to thank Dr. Poonam Bajaj from my team and Disha Hegde, who helped put it together. They are the ones who really work on the floor maximum with MS patients and other neurological patients, and honestly work wonders with them. So my task really is to give you an overview and to put across the message as to really what is possible. Dr. Meruna Bose and Dr. Gayatri will talk more about specific aspects of physical therapy, of speech and language therapy, which I won't go into much detail, but I'll just touch upon them on the surface. So let's get started. There are just some statistics. We know that roughly 7 to 10 per 100,000 people are affected with MS in India. 1 second, let me just put the screen on small so I can see. Yes. And we also know that this is an area where where pharmacology and pharmacotherapy is constantly advancing. We have disease-modifying therapies constantly coming out. So one of the take-home messages that I do want to put right away at the start really of the talk is that this is a disease, frankly, any chronic disease, but certainly multiple sclerosis, where you must be in constant touch with your treating doctor, your primary doctor, in this case, your neurologist, and keep reviewing it. This is not one of those sort of stagnant conditions where you start a medicine and you just keep taking it year after year without any titration or without going back to your doctor. So please make sure that you go back to your primary treating physician. And I believe that comprehensive multidisciplinary care is key. What tends to happen in many neurological cases, while obviously medicine is there to improve certain aspects of quality of life. For example, if you've got stroke, you may take blood thinning to prevent another stroke from happening. But I think a comprehensive rehab program is the sort of foundation or the bedrock of leading a good quality of life. I truly believe that everyone, whatever condition they may have, they need to be able to lead the best life that they can within the constraints that they have. And I think a comprehensive program is very important. And it really helps if you work with a neurologist who's very supportive of this multidisciplinary approach. So I've had a good fortune of the neurologists that we interact with at HN. Dr. Joy Desai and his colleagues are definitely of that bent of mind. So it really makes the work a lot easier and pleasurable. So in MS, we've typically focused in the past on things like gait, balance, spasticity, and of course, they're very important and continue being important. But I thought I'll just touch upon 2-3 things which maybe is not spoken about that much, which is fatigue, autonomic dysregulation, neurogenic bladder and bowel dysfunction, and neurogenic dysphagia. So I'll just touch upon these in a small way. So if we talk about fatigue, now we all know obviously what the normal English word fatigue means, but in terms of for MS patients, they defined it as a subjective lack of physical or mental energy that is perceived by the individual or caregiver to interfere with usual and desired activities. Okay. And it's also sometimes called lassitude. We use the English word lassitude, which sort of translates into, I just don't feel like. It's a sort of feeling, frankly, all of us get, even when it's so hot and humid the way it is, at least in Mumbai over the last 8 to 10 days. It just, you don't feel like doing anything. And clinically, it may manifest as lack of energy, exhaustion, increased feeling of sleepiness, and worsening of symptoms of MS. So how do you really tackle fatigue? Obviously some of these things are easier said than done. But I think
I request the host to mute all the other mics, please.
So I think one of the first thing is obviously we need to try and identify the reason and the trigger for fatigue. So different people may have different reasons and different triggers. So kind of identify them. I think it's important to help the person pace themselves. This word pacing is often important. And if you work with a physical therapist, you work with an occupational therapist, they can help you that how are you more efficient in doing some of the work that you do to help you go through your routine tasks in a more sort of physically efficient manner. Also, what happens is by doing regular exercise, by doing physical therapy, you raise your overall level of what you're able to do. Let me just give you a simple example. If today the maximum weight you can lift is, let's say, 10 kilos, and you go shopping and you are lifting a bag of 3 kilos. So today that 3 kilos represents, say, 30% of the maximum weight you can lift. And if you walk for a long distance, you may fatigue. But if you build yourself up and say after a few months, you can lift 20 kilos as an example, then 3 kilos is no more, 30% of the maximum weight you can lift. It is 15%. So you'll find that lifting that 3 kilo shopping bag becomes much easier as you get stronger. Again, given our weather conditions, you need to maybe time yourselves. You don't go out in the absolute, hottest parts of the day. Hydration, extremely important. And I think relaxation and stress management is very important. I know that one of Dr. Joy's pet topics that he talks upon is sleep and the importance of sleep, and that cannot be stressed enough. Good quality sleep and, of course, nutrition is also very important in tackling fatigue. What is dysphagia? Dysphagia is difficulty in swallowing. And I've noticed that often people suffering from MS will focus a lot on, say, walking, will focus a lot on balance, because those are some of the, how do I put it, things which are more visual, which are more obvious. People can see it. But sometimes I think things like swallowing are often ignored. And these can be, in a way, the most dangerous, because if you swallow and you swallow something the wrong way, and food goes down your windpipe, then again they can be choking, and it can be sort of life-threatening as well. Okay, so we need to make sure that you have appropriate swallow therapists work with you if you've got neurogenic dysphagia. As the slide says, it can manifest as changes in eating and drinking behavior. Because you have difficulty in swallowing, you'll start avoiding certain foods, and while you avoid certain foods, that may also cause issues of nutrition, or making sure that your body gets an adequate nutritional intake. So some of the negative sort of sequelae of having this dysphagia could be aspiration, pneumonia, malnutrition, dehydration. So all of these are things which we, of course, have to take care of. So how do you take care of it? Dietary interventions. You need to speak to a good dietitian who can discuss with you what are the foods that you should take, what are the foods that you should avoid. How do you make sure you get your nutritional needs while avoiding certain foods? So that is important. Neurostimulation techniques work. Sometimes some of these patients have hypersalivation. Oral hygiene is certainly important to maintain in this. And there are behavioral swallowing interventions which need to be taught to the patients so that they can handle this better. I do feel that speech and swallowing therapy is often an ignored aspect of overall patient care. And that's something which needs to be stressed on. And I'm sure that Dr. Gayatri will talk more about that. The next issue that often bothers patients are areas of bladder and bowel. As you know, that in MS, the signaling from the spinal cord, the pathways are blocked or they are slowed down, and therefore some of the signaling that control your bladder muscles, your urinary muscles, and your opening, the sphincters, and the bowel, what are called the pelvic floor area, that is also affected. And what are some of the symptoms that you may get? Frequency of urination or urgency. So you cannot sometimes hold back the urine. When you feel that you need to go immediately. Otherwise, you may soil your clothes. So that happens sometimes. Some people have difficulty in starting process of urination, or they get up at night many times to go to the toilet. Incontinence, they can't control it, or sometimes they feel that when they go to the bathroom, they're not able to sort of completely empty out the bladder. In bowel dysfunctions, you have sort of the two opposite ends, both constipation and diarrhea can happen. What's interesting is, again, there is therapy for this. So for example, in our hospital, we have a couple of therapists who specialize. We call it pelvic floor rehab. And we're getting some amazing results. Unfortunately, these are areas which become socially awkward and they tend to be a bit of taboo. So patients also don't often discuss them as openly as they should with their doctor. And often we don't have specialists who can help treat them. But today there is help. And please, if you do need the help, make sure you seek it. Do not avoid it. So again, both for bladder and bowel, there's a lot of lifestyle modification that needs to be done, altering the diet. There are some foods which you take or liquids that you take, which may make you go more often. So you can avoid that. But again, when you're avoiding something, you want to make sure that it's not leading to some other type of imbalance, right? Which is why the comprehensive team is required. You need your therapist to talk to the dietitian, to talk to the neurologist. So it's an all-rounded care. For too long, medicine has been practiced just in what we call, silos or in individual brackets without the team talking to each other. So I think what I want to emphasize today, if you don't remember anything else from what I spoke, is the message that the team is always important. And we always talk about teamwork being more important than just individual brilliance. And honestly, that's true for most chronic diseases and certainly for multiple sclerosis. So as we said, pelvic floor, physical therapy, there is also biofeedback. So there are machines which when you contract your bladder and your bowel muscles, you get feedback on the screen. It tells you how your contraction is, and you want to ideally train those muscles and improve the contractions. Those things can be done today. So what is autonomic dysreflexia? It occurs so sometimes often people feel very faint, or they feel like they're going to fall down. So in such situations, we always advise you to be in a seated position. That is very important. There is an excessive, how shall I say, cascade of chemicals that are happening in the body, which can sort of lead to this. And some of the signs and symptoms are you may be sweating a lot, your blood pressure can shoot up, you may feel a sense of ghabrat, anxiety, your heart rate changes, sometimes it goes very fast or it may be slow. So you need to be able to identify these, and if these kind of symptoms happen, it's very important that you talk to your doctor about that. We don't have to, we'll make sure that we don't ignore it. Okay, so in terms of prevention, again, as I spoke in the past for fatigue as well, for any of this, we need to identify triggers. I think the other preventive aspect, it's not really direct prevention, but God forbid if something should go wrong, you should have some identification on your body. So for example, when I go cycling on my own early in the morning, I wear a bracelet, and on that bracelet is my name, and it has an emergency contact number. It has 2 emergency contact numbers. That's important. Should you, God forbid, be somewhere and you maybe lose consciousness, then someone needs to know how do they take care of you. So that is very important. Good hygiene. You need to avoid infection, because a lot of times people can get infections because of this. So I think that's very important. During an episode, when you feel any of this happening, like I said, it's important that you're sitting as much as possible. If you've got some tight clothing, if you're wearing a tie and the collar is on tight, open it, loosen it. Sometimes you go to the bathroom and you sort of urinate or pass stools. That might make you feel better, and make sure that you're always well hydrated. Okay, I just want to sort of finish with giving you a couple of examples of patients and how they've done. Often we see MS in young ladies in their 40s. We had this lady, we will call her, patient X. She first came to us in 2017. And since then, so while I want to be as optimistic as possible, there are patients who sometimes do get new lesions. So this is a patient who from 17 to 22 has been coming to us. She did have new lesions, but because of constantly undergoing regular rehabilitation, physical therapy, speech and swallowing therapy, she was able to maintain, or is able to maintain, a high degree of an active lifestyle. In fact, she had shared with us that one of her goals was to going skiing in the Swiss Alps, and she managed to do that 2 or 3 years ago. And if I'm not mistaken, I think Dr. Joy Desai is also very much involved in her care and is a primary doctor.
Yes,
and,
that's true. That's true.
And now we have a robotic machine, and now some of her gait is being helped. And one of the challenges we see when we're working with patients is is also giving them, if I may use the phrase, the right degree of motivation. I believe that optimism is important, but I think that optimism must also be balanced, because, and this is sometimes the hard truth, the type of optimism where we say that I can do anything and nothing's ever going to stop me, doesn't sometimes always work, because unfortunately in some of the diseases there are lesions, there are some things which may prevent you from doing. I would prefer the optimism which says, you know what, let us accept whatever the reality is that's thrown at me, but within that reality, within the constraint that I may or may not have, let us work to our maximum potential. And I think it's our job as caregivers to sort of find that healthy balance in constantly motivating people in the right way. Not just allowing them to give in to their condition, at the same time not having unrealistic expectation, because what tends to happen is, if you don't hit those unrealistic expectations, then often there tends to be a downer. So we also don't want, patients to have those, very high and sort of low. So we have to balance that. On the other hand, we had another lady again who was in her late 40s. So this was the opposite. The first case I showed you, we saw that there was some progression in lesions, but she tried to maintain a high quality of life. This is someone who did not have progression in lesions on her scans, etc. But there was a there has been an increase in fatigue, weakness. So that also happens, and therefore physical activity therapy can also help someone maintain and manage the symptoms. So I think that is very important. Okay, so I'd like to leave you with this last sort of slide and thought, which I truly believe that movement is medicine. And this frankly doesn't apply only to MS, it applies to almost all walks of life in our body. And I think the take-home message that I want to give is that a comprehensive approach to patient care is very important. You must be in regular touch with your neurologist. You don't just meet once and continue the medicine, because medicines can and should be titrated as new medicines, as new therapies come out. They must be tried out. And at the same time, having the right amount of physical therapy, meeting the therapist for speech, language, swallowing, all of that is important. And I think having a social support of a group like MSSI, I think is so important. I know that during the lockdown, especially in the initial phase of 2020, where movement was so difficult, people couldn't get out of the house. I know that the whole group MSSI has gone out of the way to make sure that patients and their caregivers are well taken care of. So once again, thank you for inviting me here today, and I look forward to the rest of the session. So thank you very much.
Thank you, Dr. Contractor. That was very illuminating. And I must say that I thoroughly agree with the precepts that you have put forward. And on my WhatsApp status, I have a statement which says that exercise, sleep, and equanimity are medications. And this is one concept which all of us have to embrace, whether we are physically normal or whether we suffer from some unfortunate ailment that has struck our bodily physiology. So it's important to focus on movement, because movement keeps us alive. It's important to focus on equanimity, and it's important to focus on sleep optimization, nutrition. So all these pillars will support physiology and health, both when we are good and at times when we are not so good. So thank you for that wonderful introduction to some of the key tenets that MS can pose challenges in when an unfortunate individual suffers from MS. And it's my pleasure now. We'll do questions and answers in the end with all three speakers, because there are a few questions that have crept into the box already after your talk, but we'll handle that perhaps together so that the joint expertise of the three speakers can come into play for the audience in the end. So thank you again, Ashish. It's my honor now to introduce our next speaker. So can we have the introductory slide for our next speaker, Dr. Meruna Bose. Dr. Meruna Bose is currently, she's the director, I think, at the Health Sciences Physiotherapy Gulf Medical University in UAE. She's an assistant professor there. She's qualified in physiotherapy and MP therapy, neuro. Her main areas of interest are in adult neurological conditions, and it spans the whole gamut: stroke, traumatic brain injury, movement disorders like Parkinson's disease and cerebellar dysfunction, and of course, spinal cord injury and multiple sclerosis. She's published extensively in these areas of interest, and I'm certain that her expertise and her knowledge will be very valuable to all of us today who are listening. And I think she's going to speak to us about the value of physiotherapy in the context of multiple sclerosis and its fallout. So ladies and gentlemen, Dr. Meruna Bose.
Yeah, thank you, Dr. Desai, for introducing me in such a good manner. And I have a pleasure of being with you all stalwarts in your own respective fields, along with the MSSI group members, and especially Mrs. Sheila Chitnis. She is such a pleasurable, with positive attitude. She has invited me, and I accepted this invitation. Yeah, so let me share my screen with you people today. Okay, I request Mr. Javed to enable my screen sharing.
I have made you the co-host. Okay, I think this is another ID.
Yeah.
Just a minute. Yeah.
Thank you so much. Yeah, my screen is visible.
Wonderful. Yes, wonderful. We can see your slides. Yeah. Wonderful. Yes. You can go to slideshow.
Yeah. So yeah, today I think on the slide I can still see you, Dr. Desai, as in the small window, Mr. Javed. So today my topic is updating the audience about the physiotherapy management of multiple sclerosis. Thank you, Mr. Javed. Yeah, and I have been working in the UAE from 2020 onwards. And before that, I was in Mumbai, and I was always associated with MSSI as a group. And it's a pleasure to be here with the group again from the international platform. So whenever we are looking into a disease condition, we are always talking in the framework of international classification of functioning, disability, and health. So in that, we always know that the multiple sclerosis is about the demyelination of the structures of brain, spinal cord, and related structure, which affects the body function in terms of energy and drive, emotional functions, higher level cognitive functions, vision, sensory functions, urinary functions are disturbed, muscle power is altered, either it is weak or spastic. There is problem with gait and walking in multiple sclerosis patients. So whenever we are having these structural and functional changes in the multiple sclerosis patient, the patient will be always having activities and participation limitations. And that will be in terms of solving problems, carrying out daily routine, walking difficulties, relationships with the family, and problems with the employment. And all these will be influenced by the environmental factors of the immediate family members, us, the health professionals, individual attitudes of immediate family members, and the health services and systems and policies which are in and around the patient and the caregivers of multiple sclerosis. So since the demyelination of the nervous system in the different areas are there, so there are many clinical symptoms which come into picture, starting with the cognitive deficit, hemiparesis, paraparesis, quadriparesis, motor impairments like spasticity. There is a big problem with the optic neuritis. There is vision problem. There is posture and the action tremor, limb incoordination, gait instability and ataxia. If the brain stem is involved where the cranial nerves are there, there is problems with the diplopia, vertigo, speech and swallowing difficulty, etc. Spinal cord, if it is involved, then there is weakness, spasticity, impaired speech and swallowing. Okay, the autonomic disturbances like sexual and the bladder and the bowel dysfunctions, pain, and the major factors which affect the rehabilitation is the fatigue and the temperature sensitivity. So whenever we are approaching a multiple sclerosis patient or the family of a patient with multiple sclerosis, it is always a multidisciplinary approach, which obviously involves the patient and the caregivers and the family members in the center, and we, the health professionals, are all around them, helping them out, support them to come out functionally better. So there, as physiotherapists or the healthcare professionals, there are many MS-specific assessments, okay, which are there. One of the most important ones is the Expanded Disability Status Scale. Okay, it is a scale between 1 to 10. It starts with the good activity level to progressing to walking with a walker, being wheelchair bound and bed bound. And there is obviously the fatigue impact scale, various walking scales, specific walking scales like MS walking scale 12, etc., which is a patient self-reported questionnaire. So what is the role of physiotherapist? Obviously, the role of physiotherapist is to get back the function. Okay, so movement is the medicine, as Dr. Ashish Contractor just mentioned as in his end slide. So what does exactly the exercises do? Okay, the functional benefits, it enhances the cardiovascular fitness, muscle function, mobility, balance. It improves the bone density and it improves the cognitive function as well and improves the mood. So when you exercise, you feel better, you feel good about yourself. And it reduces the secondary diseases, it reduces the fatigue. Actually, exercise should reduce the fatigue in the multiple sclerosis patient if it is done in appropriate dosage. Okay, and it helps in reducing the depression and decreases the fall risk. So exercise schematically, if you see, or conceptually, if you see, it influences the immunomodulation. It is anti-inflammatory in nature and pro-inflammatory in nature. It improves and it reduces the neurodegenerative environment. So what happens is the brain is improving. The brain health is improving in terms of neurogeneration and it improves the neuroplasticity. When the brain health is improving, when the neuroplasticity is triggered, it attenuates the disability and it enhances the health and quality of life. This is what exercises do in a nutshell. But we as therapists always are faced with challenge when we are dealing with a multiple sclerosis patient. So whenever we are exercising a multiple sclerosis patient, there is a concern of elevated or core body temperature. And when we are exercising them, it might increase. Okay, it can increase the symptoms as well. Then there's a problem of obesity. The lack of physical activity, which has caused obesity in patients in multiple sclerosis, it affects the rehabilitation outcomes. There can be disrupted sleep. As Dr. Joy Desai said, sleep optimization is important. And if it is disrupted with things like pain and urinary bladder and bowel control, then it is difficult for us. Then affective disorders like depression, then stress of the patient affects the rehabilitation outcome. And other medical conditions such as anemia also affects the rehabilitation outcome. A multiple sclerosis is not a stagnant disease. It keeps on progressing. It is benign sometimes for some cases, but in some cases it is having symptoms, and again there is a relapse remission, and sometimes it is progressing. So at different point of time, we have different goals. Okay, so let us arrive at that. So when a patient is just diagnosed with multiple sclerosis, what we should be doing? We should evaluate the patient at the baseline first. Okay. At this point of time, a healthcare professional will educate a patient with multiple sclerosis, making them aware of the condition, explaining them about the importance of the exercise, explaining them about fatigue, and if there are some symptoms like weakness or problems with the balance and the gait, that has to be addressed. The follow-up visits at this point of time is infrequent. Probably it is one session per week or one session per month. Now, when there is relapses and remissions, at the time of stability, patients should be consulted 3 to 6 months for rehabilitation for tune-up. We go to the doctors if multiple sclerosis patients are there in this audience. If you are a patient, you should be, if you are okay, you are feeling okay at this point of time, it doesn't mean that you are stopping to exercise. You have to keep exercising, and you have to go to your therapist even if you don't have any symptoms for basic tune-up. That time the therapist will assess you on strength, balance, flexibility, and cardiorespiratory abilities, and give you the further plan of exercises. So no symptoms, not having nothing doesn't mean that you are not exercising. So during a relapse, when there is the symptoms which is aggravated, so our role as a therapist will be to bring you back to the baseline functioning, what you already had. So when there is relapse, that time we are not giving you any exercises. So we wait for at least 2 weeks, and this duration depends on the severity of the attack you are having, influence of the corticosteroids if you are taking, or the level of function prior to the relapse. So here our goal is to have safe mobility, gain back your optimal functioning, and give you personalized exercises at that point of time. This period of time, we counsel the caregivers and family because they face a major setback with the functioning, because the patient was all right and suddenly had a relapse. So we have to counsel them. We do counsel them that they will get back. We are trying to get back to whatever the patient was in a functioning status. So counseling of caregivers and family is important aspect at this phase. So if the patient is progressive, is in a condition where it is a progressive kind, so patients generally do not return to the baseline functioning. So here our goals are to support, resource, avoid the deconditioning, maintain the safety of the patient, and maximize the health and independent function. Here we need to assess the need of mobility aids at present as well as the future. So here we will be communicating with our multidisciplinary team members, especially the concerned doctors with the patient. In the advanced disease condition, we specially target trunk positioning and control, making the patient sit, transfer training, okay, upper extremity strengthening, improving the respiratory function and the equipment needs. So here we train the caregivers for transfers. Most of the patients will be either wheelchair bound or bed bound, okay, or they are using walkers for walking. So we need certain things like gait belt. So this is how a gait belt looks like. Okay, it's a belt like with grip. Okay, you can hold and make the patient walk. If the patient is bedridden, then you can use belts like these. You just slide it below the patient and you can pull the patient up on the bed like that, or from the wheelchair. This can be also used for pulling the patient up from the wheelchair. Here we have to focus more on the physical health of the caregivers. Why? Because the physical activity of the patient, rather than the patient, it is more of the caregiver. So the patient's caregiver should be more fitter. So we have to prescribe exercises for them, advise them to keep fit so that they can deal with the patient with multiple sclerosis here. Now, when we are talking about a person with multiple sclerosis in advanced condition, it is always encouraged that the standing devices are used. For example, a standing wheelchair. So it is in a study by Freeman 2019, and which was published in Lancet Neurology. They said they made a protocol named SUMS protocol, standing up in multiple sclerosis. So here we encourage the patients to stand for 30 minutes, 3 times per week over 20 weeks. And it might continue for longer term if the patient is able. So it has been found to improve the motor function, weight bearing. If the patient's lower limbs are spastic, it helps in stretching, prolonged stretching. It helps the patient in bowel and bladder relief. It improves the respiratory functioning and functional independence in the patient. If you see in this picture, this lady can stand on the standing wheelchair and probably do some few kitchen work or the counter work while standing for 5 to 10 minutes. So it does give a little bit of functional independence to the patients, and it feels nice. So now coming to the my presentation will come to the specific symptoms. Now, if the patient is having weakness, okay, it can be a primary weakness because of the demyelination which affects the anti-gravity muscles, or the secondary weakness, which is disuse because of disuse, deconditioning, pain, or spasticity. Here, we will recommend that we assess the 1 repetition maximum of the patient and only give 60 to 80% of the repetition maximum. And we only target 8 to 15 repetition in one set. We will give 1 to 3 sets, okay, in a session, and you will give 2 to 3 such sessions in a week, okay? Only if the patient is achieving a 15 repetition of that particular movement, then only you will be increasing the resistance by 2 to 5%. You will ensure that you are taking rest 2 to 4 minutes, or the physiotherapist will assess that whether the rest is enough, how many minutes rest is enough. And the therapist will always target the large muscle groups in this case. When we are coming, when most of the patients face problem with the spasticity and flexibility. So inhibitory techniques for spasticity reduction, like prolonged stretching, weight-bearing exercises, positioning against the synergy patterns, antagonist activation, PNF techniques, okay, hydrotherapy, okay, these things can help in spasticity reduction, improving flexibility. Splints and serial casting are assistive devices which will help the patient's muscles to be in a prolonged stretched position. Balance. So balance is affected in the patient, and our goal as healthcare professional is to reduce the risk of fall. Whenever balance is altered, you fall frequently. So we will progressively challenge the manipulation of somatosensory input during sitting, standing, and walking like this, probably giving you exercises over the Swiss ball, or making you walk over the foam surfaces, or give you dual task training. Okay, we are constantly challenging you on the balance and training it out so that the fall risks are reduced. Talking about coordination or ataxia, so there are 2 kinds. So when the sensations are affected, the proprioception, the kinesthetic awareness is affected. That time the patient probably will talk to you like this, that I cannot walk unless I can look at the feet. I cannot walk without that, looking at my feet, or I want to look at my feet. So that is a clear indication of sensory ataxia. In cerebellar ataxia, you will have cerebellar symptoms like the dysmetria or diplopia will be there. Okay, dyssynergia will be there, and patient will not be able to walk in a straight line. So along with the coordination exercises, like we all know, we can give Finkel's exercises, equilibrium exercises, non-equilibrium exercises. Along with that, you can consider about balance and splinting, using light weights in the extremity. If you use light weights in the ankle area, probably the patient will walk in a better manner what he was walking before. So use of balance-based torso weight like this. Okay, this is an image of balance-based torso weight. It's a vest. It has weights. You can use the weights around the vest, and that gives you the proprioceptive input to have better coordination amongst the muscles which are co-contracting during the movement. Coming to aerobic endurance, aerobic fitness, I think Dr. Joy said Dr. Contractor is the fittest consultant. So probably we should be aiming at the fitness levels. Okay, so when we are doing at looking at aerobic fitness, it is said, or the evidence says, that it decreases the lesion and it decreases the brain atrophy. It increases the neural remodeling and regrowth. So how we have to give aerobic endurance for multiple sclerosis patients? So you can give it in the form of swimming or a stationary bike or an arm bike if the patient's lower limb is not functioning, or simply advise the patient to just walk for 20 to 30 minutes. And he or she should be able to walk for 3 to 4 sessions per week. But the intensity has to be taken care of, because as per the rate of perceived exertion, you should be telling the patient that you should be able to walk, talk while you are walking or doing the aerobic exercise. So it should be, the intensity should be 3 to 5 on RPE out of. Respiratory functions, patients are ambulatory, they can walk on their own, they can be non-ambulatory. But even it is assumed that if the patient is ambulatory, the respiratory function is all right. But however, it is said that even if the patient is ambulatory in multiple sclerosis patients, approximately 30 to 80% of the patients have weakness in the inspiratory and the expiratory muscles. So non-ambulatory definitely will have. So it is important that we give respiratory muscle training 3 sessions per week for 30 minutes. Okay, and you can exercise the respiratory muscles by moving the upper extremities on different directions, maybe lifting the shoulders or moving the shoulders. Okay, opening up the chest and moving the upper limb front. And you can use devices like the breathers. Okay, there are various devices with the resistance control. You can use these kind of devices for respiratory function training. Yeah, fatigue is a major component. We talk about exercises, but fatigue has to be considered. And we told that the modified fatigue impact scale, along with that fatigue severity scale, is also there, which can measure the fatigue. Okay, so we have the intervention should focus on 4 P's. You have to pace the activity, you have to plan the activity, you have to prioritize the activity, and you have to position whenever the person is doing any activity or exercise. The positioning of the person or the patient with multiple sclerosis is important. You have to simplify the exercise and give task simplification if you are giving any task to do. You have to use the adaptive equipment or assistive devices and use strategic rest breaks. You can think about environmental modifications like the high toilet seat or the Velcro strap or the zipper, or you can use a pen holder, okay, while writing. Now, while preparing for this talk, I came across this particular protocol. They said that the fatigue can be definitely influenced by cognitive behavioral therapy and energy effectiveness technique. And you have to focus on normalizing the fatigue experiences, make the patients learn helpful ways about thinking about the fatigue, and maybe giving them scenarios so that they can think about using the available energy which is there more effectively. So this is a facets trial. This is fatigue applying cognitive behavioral and energy effectiveness techniques to lifestyle. Approximately, this study did 6 sessions for 90 minutes duration, weekly in groups, and it was conducted by 2 health professionals, physiotherapists, nurses, occupational therapists, anybody in the team of multi-MDT. And they found that the fatigue improved well, and it even was retained. The beneficial effect of this these sessions remained till 4 months after they stopped the trial. Then another problem that patients face is the cognitive difficulties. So in that case, they have difficulty in remembering what exercises you are giving the patient. So teach the patient to make lists, use calendar for appointments, make a diary, organize the environment. you try to limit the noise during the conversations when you are having with the patient, or ask the patient's family to reduce the noise when they are having conversations. Have the patient repeat information and write down important points. This is generation effect. And encourage use of crossword puzzles so that their brain is sticking and cognitive function tests can be applied. You can use face name technique, probably use an old photo, okay, who is this, and you can ask. So cognitive rehabilitation plays an important role. So there are many things to be I can go on and on, but to summarize, the exercises should be challenging for the patient, but the patient should never struggle. That should be our aim. Okay. You should follow the 2-hour rule, especially the patient. If you do not feel that you have recovered from exercise within 2 hours, you did too much in that session. So next session, you make sure that you are not doing that much. Okay. You should be able to recover from the exercise effect within two hours. Okay. You have to have frequent rest breaks. You can use cooling strategies during exercises, like probably having a cold pack or exercising in an AC environment will help the patient. Okay. Cognitive difficulties and mood changes definitely influence the outcomes, but you have to keep the patients and the caregivers motivated. Use SMART goals. Let me talk about the SMART goals. SMART means specific, measurable, achievable, relevant, and time bound. So you give this SMART goal to the patient or the caregivers. For example, I will work with you for 8 weeks, and you will be able to stand with walker for 5 minutes while helping your husband to prepare dinner at the kitchen. So this is a task specific, achievable, relevant to the patient, and it is time bound, that this I have to achieve in 8 weeks time. And once the patient is achieving these small bites, small bit of things, they feel nice. Okay. So you have to have SMART goals and these SMART goals should be broken up from the short-term goals what you have set for the patient. So hope is our only, so we as therapists should inspire hope in the patients and the caregivers, give them resilience and happiness through the movement which we give the patients. And thank you for the opportunity. And this is my end slide.
Thank you, Dr. Meruna. That was a very comprehensive assessment of the role of physiotherapy and Dr. Contractor's concept of movement and maintaining movement to stay good. We'll be taking questions in the end, and it's now time to introduce our third and final speaker. So today we have with us Dr. Gayatri Bhattacharya. She is the professor and head, I think, at the BYL Nair Hospital. She's the associate professor, yes, and the head of audiology at the Tiruvannamalai National Medical College, BYL Nair Hospital. She has attained her qualifications from the University of Mysore and subsequently from Mumbai. Her areas of interest are swallowing disorders and communication disorders from pediatric to geriatric population. And I believe today she is going to share her knowledge, experience, and wisdom on the role of swallowing therapies and therapies for aiding patients with deglutition and disorders in multiple sclerosis and speech. So I guess a lot of her emphasis is going to be on rehabilitative strategies for speech dysfunction and disorders of swallowing under the umbrella of MS. So welcome, Dr. Bhattacharya, and the stage is all yours.
Is my screen visible?
Yes, it's great.
Yeah, you can hear me?
Yes, super.
Okay. Okay.
And may I request in the beginning, all the others who are part of this webinar to mute their mics, please, so that our speaker is not hindered. Thank you.
Thank you. Thank you so much, Dr. Joy, for this introduction. And I thank MSSI for giving me this opportunity. And I also wish to thank Mrs. Sheila Chitnis. She's a wonderful person, very warm, a good, lovely human being. And as my previous speaker said, it's very difficult to say no to her. In fact, I don't think she even she said, it's so nice that I have been able to get in touch with you, Gayatri, and you'll be talking about this. So it was like a given that I'll be doing this. And I'm so happy. This is the first time I'm addressing the MSSI. So I would like to begin with the it's not going.
Your slides are not moving.
Yeah. I would like to start with this prayer where in the Bhagavad-Gita, the Lord tells Arjuna that Yukta Hara Viharasya, Yukta Cheshtasya Karmasu, Yukta Swapna Avabodasya, Yogo Bhavati Dukkhaha. So what he says is, to him who is temperate in eating and recreation, in his effort for work and in sleep and wakefulness, yoga becomes the destroyer of misery. So there, though the yoga means where the Lord is encouraging him to have union with the Lord, here in this case, I am trying to use it to this advantage that even for all of us, like we earlier heard about, how to, kind of for daily, even maintenance of our self and fitness, we need to do exercises and we need to follow. So this is a preventive aspect as such that if we kind of are temperate in our eating and recreation in our effort to work, like just now our previous speaker said, Dr. Meruna said that if the exercise is too much, then the person will not be able to recover within 2 hours. So if everything is temperate, even for our patients, persons with the multiple sclerosis, it will go a long way to have this balance and to keep this fact in our mind. I would briefly like to cover about communication and swallowing difficulties in persons with multiple sclerosis. A few terminologies which are very, which we will be using in terms of communication and swallowing. Prevalence, characteristics, very briefly, because the topic is rehab and I want to stick to that. So my focus will be on rehab strategies for communication and swallowing. We keep using these terms, but just to have a little, so that we can differentiate between this. Cognition, I feel, is like the ocean, vast and complex. And the assessment of cognition is feasible, but complex and time consuming. And we can only aspire to measure a sample and then relate it to the whole. And we need a specialized team and an integrated approach to do so, for which we require a neurologist, a psychiatrist, a neuropsychologist, a psychologist. If all four, great. If not any, as many of these as possible, because each of them looks at cognition, each of them looks at the brain in a different way. And this aspect is very important for us, not just when we are viewing multiple sclerosis, but when we are viewing any aspect related to the brain. Language, I feel, is akin to the river and its connect with the ocean. So in a way, it is very linked to cognition. So it is irrevocably linked to cognition, and its assessment is complex, but less complex than cognition, I would say. And there are many tests which can assess the cognitive linguistic competence. Earlier, we used to call them as language disorders, but now very sensibly, the terminology has become as cognitive linguistic impairment, because we cannot really separate out language from cognition. And these tests are administered by the speech language pathologist. And in terms of multiple sclerosis, rather than having one specific test as such, which will assess all the aspects, what we prefer to do is we combine subtests of various tests. So sometimes something from the right hemisphere impairment assessment module, that helps us, something from aphasia helps us, something from dementia helps us. And we are more trying to customize it for the person's requirements as such. And language, basically, when we say language, what is it? Is it Hindi, Marathi, English, that aspect? That is one aspect, yes. But when we speech pathologists use language, we talk about it as the science of, kind of the linguistics is a science of language. So what is it? Phonology, wherein the rules governing the sound system of language. Like there are certain certain time where, kind of certain sounds like is very specific to Marathi, but it doesn't exist in Hindi or English. So which sounds are in our language? Very briefly about that. Syntax is the grammar which connects words together as per the rules of language. Like in Marathi, Hindi, and Devanagari languages, it is the subject, object, verb order. Like mulga shayad gela, ladka pathshala mein gaya. So you will tend to use the verb at the last, whereas English, it will be the subject, verb, object, where the verb is in the center as such. This is just to give it is just to help us understand the grammar of a language. Semantics, when we say what are we talking about, we are talking about vocabulary, we are talking about the meaning or meaning bearing units of language. So where it could be like categories like fruits or names of girls beginning with the letter S. It could be, kind of a specific task like names of comedians from the Hindi cinema. So it becomes a little more, you have to think a little, or it is open, like things you like to do. So it could be very different from A person to B person. Now, if you think, syntax, semantics, and seems is a little easy to understand, then what is morphosyntax? Morphosyntax is semantics and syntax in application and the link between cognition and language. Just to give an example, I would like to talk about this, where if in a sentence, the man chased by the dog ran up the tree, if I'm asking this to a patient and ask him to show me the picture it talks about, which is the correct picture. Now, each of them have something to do with the sentence. So if I have not heard all the units properly, if I'm not attentive and I've missed the first part, or I've missed the last part, or I missed the passive aspect of the sentence construction, I might pick it up as the picture where the dog is chasing the person or boy, the man on the cycle, which is again not what you want. Or if I just hear it as the man chased the dog, I may go for the picture where the man is running after the dog. If I just hear the words the man, dog, and the tree, I might go for this last picture where all the three are there, but this is not what the picture is. So morphosyntax is again, so when we are dealing with persons with complex disorders where cognition is also affected, we needed to see whether basic comprehension may be intact. But if I ask a sentence like this, is the person able to understand and apply correctly? Then what is language? And the other aspect is pragmatics, which I consider as the most important aspect of language, because it is effective use of language in a communicative context. So what is your communicative context is where you are in the situation that you are. Like I will not speak the same way if I am, kind of in the library or so. I'll be talking softly. I'll be talking very minimally. If I'm with my friends, I will be, very involved, and I'll be talking in a louder voice. I'll be very freely. I might use slang even, So that way it will be the situation which will demand this. And if I use this inappropriately, it is going to affect my communication. So first of all, I have to have an intent that I want to tell you something, or, you know what happened. So I will begin with that. That is, I have an intent to tell you something. There has to be shared background between those who communicate. So suppose a friend asks another, how was it? The third person may not know. Maybe they are referring to a movie which one person saw, or some experience that the person was relating to. So background has to be there. And discourse is conversation, which is like, say, suppose you are asking the person to talk about inflation or life in Mumbai or about Oscar awards. So how the person will initiate the topic, how the person will maintain it, how the person will shift from one to another, how the person will repair it. Like just to give an example, in the previous session, the Dr. Meruna was talking about it. So she has initiated it, she's maintaining it. There was some disturbance, but she continued sticking to it. So she didn't allow her communication to, fail. So the disturbance did not cause any disturb. So she repaired it in her own way. And another is turn taking. When two people are speaking, there has to be a reciprocity between the speaker and the listener. Sometimes I am the speaker, sometimes my listener becomes the speaker. So this aspect has to be clear. Why am I going in details about this? Because I have seen that in Parkinson's disease, sometimes the disease pattern is very different, its manifestation is very different. In multiple sclerosis, we sometimes see a little involvement about cognition, a little about language. So you see more of a patchy, involvement about speech, language, swallowing. And also it is important to know that Is pragmatics also affected? Can they hold on to a topic? Maybe at surface level, if you just ask them to name objects, they might be able to name, but higher language may be affected, and hence this I felt I needed to talk about it. So pragmatics, just to give a in a very brief aspect is, just as dress codes vary, so do our speaking styles. So just as here, you can see the fashions, the dress code is different for a business function or a casual wear. Or just as a lady won't wear heavy brocade when she goes for a picnic and not the other way when she goes to attend a wedding. So this is something like we should know how to use language appropriately. Sometimes, very occasionally, doesn't happen, except in perhaps very severe, where the advanced multiple sclerosis condition is. But otherwise, pragmatics as such is not really very much affected, but we need to keep that in mind. Speech, on the other hand, is akin to a large lake, expansive and deep, but more well-defined and hence easier to measure. So what is speech? When I want to say something, I first begin with the breath. Of course, the message and everything comes from my brain, but the act of speech as such starts with the breath, and then the voice comes at the level of the vocal cords. The breath gets transformed into a voice. The voice gets amplified because of the resonant cavities of my pharynx, my nose, nasal cavities, and my oral cavities. And then the articulators, that is the tongue, the lips, the jaw movements, all these aid in production of sounds as such, so the articulation. And then when I say there has to be a rate, a pause, a rhythm, a stress when I'm speaking, like I think this is really good. When I say really good, it is the stress that I'm giving which adds meaning to what I'm saying. So all this is best tested in reading or conversation. Respiration, as we know, can be tested by spirometry or so. I'll discuss this 5x5 rule when I talk about the rehab. Phonation, we do acoustic analysis where the instrument itself measures when the person just has to say vowels like a, e, u, and may count, may say a few lines or so. And it just gives us a fundamental frequency, harmonic to noise ratio, gives a lot of information related to the acoustic aspect. And this is very crucial for persons with Parkinson, with the multiple sclerosis, because very often their voice is affected. Sometimes it is very low in intensity. Sometimes they're not able to manage pitch aspect as such. Sometimes they are having a little strain in the voice. So all these are picked up by the acoustic analysis, and we can use that as biofeedback when we are giving them therapy. Suppose I do not have this equipment, I can just ask the person to do a phonation duration. That is, just take a deep breath and just free phonate, like just say till the breath the person's breath runs out, and then measure that in 3 times and see which is the best aspect as such. So if the person may have 12 seconds, or if it's very restricted, it may be 8 seconds, 6 seconds. So then our therapy aims at extending that so that you have a good days to the voice as such. So here I will again later on talk about the concept of intelligibility versus comprehensibility when we talk about the rehab aspect. So very briefly, I'm going to talk because my intention is to focus more on the rehab strategies as such, but just to have an idea of how much are the communication and swallowing disorders, how prevalent are they? So a study which was done in Sweden, where they had asked 5,289 persons with multiple sclerosis were asked to self-report. And they found that nearly 2/3 reported that cognition was affected to some degree. 1/3 perceived difficulties with speech, and most they had like word finding difficulty, or they were going off the topic. As I told, maintenance of a topic, repair of a topic breakdown, all these are very important. So this is sometimes seen in persons with Parkinson's disease. Persons with multiple sclerosis. 4 out of 5 respondents had at least one of speech communication problems, such as speech-related fatigue. Dr. Meruna talked about fatigue in terms of the physical aspect of it. The same thing is going to be seen, like it is like a microcosm of when we are assessing speech, it is like all the, however the movements are being affected in the rest of the body in terms of walking or sitting, standing, you are going to see a similar pattern in terms of the speech muscles also. So we do see speech-related fatigue and imprecise articulation. Even the articulation is imprecise because the range of movement for the tongue to reach the palate or reach the alveolus or reach the back of the palate, all these may be, kind of very fleeting, and they are not very specific enough. So the articulation or the pronunciation is imprecise. Owing to speech difficulties, 1/3 had changes in professional or social roles and participation. I think again, Dr. Meruna had touched upon the ICF aspect as such, and definitely their functioning is affected when speech is affected. They have problems in maintaining their jobs or maintaining the standard and the quality of their job that they were used to doing. And this has a great impact on their mental status as well, where their participation gets affected. So a small group also reported swallowing problems. 1/4 of persons with multiple sclerosis had swallowing difficulties when another survey was done on 400 persons with multiple sclerosis. It was seen that even this study, when done abroad also, they had found that very few had received the services of a speech language pathologist, and most commonly voice was trained, but not so much in terms of articulation or language or respiration also, which needs to be kept in mind. The swallowing difficulties, it was seen in another study that 25 to 35% of persons with MS show subtle symptoms of affected respiration, affected voice and swallowing functions. And more than 65% are afflicted with impaired respiration and swallowing. And this is seen to be more common in persons who have cerebellar plaques. Swallowing difficulties were seen 1 out of 4 respondents in the survey done by them, and 1 in 3 had speech problems. Okay, this I'm very happy to share with you, because this study was done at Nair, in fact, with the help of MSSI itself, and special thanks to Mrs. Sheila Chitnis, who had given us a lot of support at that time. A student of mine, PG student of mine, had taken it as a dissertation topic to analyze the problems of swallowing seen in persons with multiple sclerosis, and as well to try the efficacy of treatment and how it works with them. So 60 participants were evaluated using this test of which we had developed at Nair Hospital. It's a Nair Hospital bedside swallowing assessment and Nair Hospital swallowing a severity assessment scale. So where 9 out of 60 persons were, that is 15%, were identified with significant dysphagia. Both oral phase as well as the pharyngeal phase was affected. 3 had oropharyngeal and 6 had oral stage of dysphagia. Their severity was that 5 persons had mild, 2 had moderate, and 2 had severe dysphagia. Comparison of the swallow scores, Comparison of the swallow scores, the swallow duration for 5 consistencies, severity of dysphagia, all this was worked on. So what did we do? We gave each of them, trial with 5 consistencies, and we saw their response. And this was measured as it was taken as a baseline. Then they were taken for sessions. The milder ones were given 4 sessions. The moderate ones they required 8 sessions, and those who had severe dysphagia had 12 sessions. And their swallow duration for these 5 consistencies was compared, and their swallow scores on the above mentioned tests were compared. We also saw, because we treated them with postures, additional postures, maybe to a head towards the weaker side or head towards the stronger side, or maneuvers, which I'll be talking about, exercises, which I'll be talking about. So those were given to them, and after therapy, again, the measures were taken, and we found a very significant difference. We found a significant difference in their dysphagia scores, where the mean scores pre-therapy were 17.33 and post-therapy was 9.66, where you can see that these are the 9 patients who required it, and you can see the scores pre and post. The higher scores indicate more severe dysphagia, and the lower scores indicate a lesser, better control of swallowing. So you can see in all the patients, there has been a reduction of the scores post-therapy. That means, why am I happy to explain to this, that therapy does work with persons with multiple sclerosis, and we have proved it with kind of statistical significance also. 2 of them went from a degree of severe oropharyngeal dysphagia to mild, and 2 with moderate went, they are later on showed mild oral dysphagia, and 2 had shifted from mild, they went to normal, and 3 who had mild went to slight. That means there was a change of their status, and this again was an encouraging response as such. And mind you, the ones who were severe also showed. That is a very significant aspect. Not just the mild and the moderate, but even the severe went to mild oral dysphagia. So this shows that therapy really does work for such patients. So again, very briefly, I think I'll now go more in terms of, this is just, I just want to say that persons with multiple sclerosis have consonant imprecision, a reduced speech rate. So their rate of speech becomes slower. They slow vowel transitions. So suppose I have to say a word like vowel, where I am going from one to another. So this vowel transition as such becomes a little difficult, because in vowels, it's a little abstract. The position in the mouth is not really specific by touching it somewhere. So this becomes a little more difficult in persons with multiple sclerosis because of the slower tongue movements. They have decreased loudness control, vocal instability. What is instability? They are unable to hold on to the the pitch that they had begun with, or the strength or intensity that they were used to. So there is instability, either the loudness fluctuates or the pitch fluctuates. And this again causes embarrassment when they are talking, especially if it's work or social situations, it may create embarrassment. So they have a reduced speech rate, increased duration of frequency of pauses. And again, it changes. Like when I'm talking to you, suddenly if I speak slowly, you are going to immediately attend to the way I'm speaking rather than to what I'm saying. And this again affects their communication. Now, language is in terms of, sometimes they resemble a problem like aphasia, where they have, they are unable to comprehend the essence of it sometimes, or some days it is worse than other days, but where they have comprehension and expression may be affected, or repetition may be affected, spelling may be affected. One more thing which we see, and which is why I said that when we are looking at their assessment, we don't only take one assessment test as such, because they have sometimes difficulty in interpreting ambiguity. What is ambiguity? Like sometimes, like when we are saying something like the two sisters, Susan and Lisa went to the market. She bought a shawl for herself. Now here there is an ambiguity that between two of them, who bought it? So sometimes a picture or something may have indicated. So when I'm communicating, am I missing on that aspect? Am I not able to take what is ambiguous? Or in that sentence, like earlier shown to you, the man chased by the dog ran up the tree. Who ran up the tree? Am I confused whether it is the dog or the man? So those aspects, or metaphors or inferences, after hearing a narrative, to say what was it actually, so that inference again may be a problem. So some of these problems are seen in persons with MS. Now, what would be strategies for rehab of cognitive linguistic difficulties? As I said, we may have to work with a neuropsychologist or a psychologist, but some of these tasks, whether an occupational therapist, or speech language pathologist, or psychologist, or a neuropsychologist, we sometimes use these because though our goals are different, some of the acts, it helps us to achieve the same. So we may want to begin with better attention building tasks as such. So this is like a letter cancellation test. So suppose I say cancel all the letter O that you can see, or I can say that cancel all the K that you can see. So how much is the person able to focus on this? And later on, we can see which ones he missed out, whether that is telling us some information that all from the right side are missed out, left side are missed out, the above ones are missed out, etc. So similarly, you have a shape cancellation task. Then these trail tests are very, very useful, where as children, we have all played this, like we join the dots from 1 to you go to 2, then 3, 4, etc. Sometimes you have these mixed trail tasks, which is like, you have alphabets and numbers. So you have to go to A1, then you have to search for B2, then C3. So that way it helps to engage them and, challenge their cognition and help in cognitive rehab. Sorry. So this is again in terms of memory as such, when or sequencing, visual sequencing when we are telling. So is it like, which of the pictures in the second frame that I'm showing? So here the person has to say that, the girl first picks the apple, then the mother bakes it and makes an apple pie, and then the child eats the apple pie. So am I able to use visual sequencing as such? Or visual memory? In the right side, you can see a lot of pictures. if I give this sequence, or if I give this for 2 whole minutes, the person has to see and then make a list of which ones were there. Or if I make it easier, I may give after 2 minutes, I give a same plate and the person has to another plate is given where about maybe 8 of objects are there which were from this and 4 others which don't belong to this picture, and the person has to identify which ones he had already seen, something which will challenge the visual memory as such. Again, memory building can be auditory memory also, where you have forward digit span, backward digit span, those kind of tasks where you begin with a simpler one like 7, 9 or 5, 4, 2, and then you go on to like a mobile number 9, 9, 8, 7, 6, 3, 5, 4, 6, 2, and whether the person over a period of sessions is able to improve in his auditory memory, because this will help him to have a better this about the language aspect as such also. Okay, then in terms of quickly going to semantic tasks, they could be like word completion tasks, word association tasks. So what are word association tasks? Like suppose I say cup and the person has to say saucer, okay, up and down. So sometimes with antonyms, or I say sister and brother. So the synonym, words which go together. Synonyms are words which are similar meaning. So those challenge your semantic memory as such, which is sometimes affected in persons with advanced multiple sclerosis. Naming items within a category as such. So which examples I had given earlier. So names beginning with a particular letter, etc. Completing a phrase. When I went to the fair, I did, or I saw, or I bought, something of that sort. Or sentence construction. I'm giving you 2 words. My sister market. So make a sentence out of it, or describe a picture, etc. So now syntax building task could be, completed with appropriate syntactic markers like I eat dash a spoon. So I eat with a spoon. Or after I peel the fruit, I will eat it. So whether the person is able to arrange it. Or rearrange the following. If I give a scrambled sentence, whether the person can rearrange it for me. I just wanted to also give an example, like in today's day, because we use a lot of email IDs. So whether the person, if I scramble an email ID, and especially if it's that same person's email ID, whether the person will be able to unscramble that. And then pragmatic stimulating, like, is you engage the person in conversation and check whether turn taking is appropriate. Or talk on a given topic, like what I liked about the lockdown period. Yes, there were a lot of disadvantages, but there must have been some advantages also. And check for all these which I discussed earlier. And see whether the speaking style is appropriate for the person's age, background, and the context, communicative context. So speech again is where you improve the respiratory control by deep breathing, pranayam, aerobics, okay? And again, aerobics again with consultation with the physiotherapist in terms of so that the person doesn't overtire himself or herself. Then utilize breath effectively. So here the concept should not be like, I have to just pre-phonate for about 10 seconds. It is how am I utilizing the breath effectively? So the person should not speak on exhausted breath, but rather than, even if it is like I can sustain 3 words, I had gone to the market. So if you can just say these in that one breath, you can use 3 words, it will still be a more effective way of communication. Hickson's 5x5 rule is that if he found out that if respiratory pressure of 5, the pressure of 5 mm mercury is it can be maintained for 5 seconds, then it can be considered effective for speech. So simple device like this, where a measuring glass, and he had, you can stick a straw in it and fill it with water and see whether for 5 seconds the person is able to blow bubbles into it. So that means he is continuously blowing bubbles, means he is able to have the respiratory pressure maintained for 5 seconds, and that gives him enough basic respiratory pressure for speech. Phonation is, you can go up and down the scale, or how like in music classes they teach like sare, sare ga ma, pa, and that way the person goes up and down the scale he can go. Increase loudness of voice by, suppose the person's name is Rahim. So he says, my name is Rahim. So he starts softly, but then he goes on increasing. So he's taught to have better loudness control. If voice is hoarse, harsh, breathy, then you may need an ENT opine and voice therapy from the SLP. Resonance can be generally is not affected in MS, so I really won't talk much about it here. Articulation, there are very simple things like if articulation is not clear, a technique is consonant exaggeration, where as I've marked in red, you stress on the consonant. So consonant exaggeration. So if a person's speech is very imprecise, you may use this extra stress to pause for some time so that your speech becomes clearer, or you break it syllable by syllable. So syllable by syllable approach. So I'm not putting more strain or exaggeration, but I'm just pausing there so my speech gets better clarity. Prosody can also be worked by slowing down the rate of speech, or a contrastive stress drill like I love cricket, I love cricket, I love cricket. So it is like also where the meaning bearing words are, we can say. So intelligibility.
Run out of time.
Run out of time. Okay. I have not been able to give the techniques for swallowing, but what I can do is I can answer it in the, I can show these demos if allowed to in the question answer session. So this is, I just want to end with this, that I want all of us to remember this, that it's one step ahead every time. Our race is only with ourselves, and be mindful of this moment and rejoice that we are still alive. We have survived COVID. We have seen so many problems and we are still alive. So we have to be mindful of that and deal with whatever is on our plate. So thank you very much. So the following strategies I can show as a quick demonstration during the question answer section. Thank you so much.
Yeah, thank you so much. Very, very informative talk today. However, we are seriously behind schedule.
I'm so sorry.
To finish this by 5:30. No problems. What we can do, we have numerous questions in the chat box that have been proposed by members of the audience. I shall use my moderator's prerogative to select those that I think need to be brought to this platform. So why don't we start with some of the questions that have come through. Someone has asked a question that would appreciate if someone can throw light on hammer therapy. I personally must confess, I have zero idea about hammer therapy, but Ashish, Dr. Meruna, and Dr. Tangri, anybody can shed light on this question?
I will start by saying I too have zero idea, but since this was posed and we had time, I actually went and Googled it. So I think it's something done by chiropractors, and honestly, there's very little information even online of any evidence of it working. So I mean, I don't know anything about it. So I think it's important that if somebody is undergoing a certain therapy, please speak to the therapist, whoever that might be, and just ask for some literature, some evidence on it working. So any of the other panelists have any other answer on this one, please share it.
Wonderful. There is a question for Dr. Meruna, which deals with swimming to fight spasticity and stiffness. And I think in the same vein, maybe she can also explain if she has very specific strategies she would recommend on improving balance. So we can do these two questions together. Dr. Meruna, question to you.
Yeah, thank you for the questions, audience. Yeah, when we are talking.
You have muted yourself.
Meruna, your mic's got muted. You have to unmute yourself. Yeah, super.
Sure? Okay.
Yeah, good.
Sorry. Yeah, thank you for the questions. Yeah, spasticity, when it is aquatic therapy and spasticity, there has been evidence that if we are exercising the multiple sclerosis patients inside the water with the limited voluntary control, because of spasticity, what they have inside the water, they can do more larger movements. They can move. Okay. Also, it has additional heat, controlling the heating of the core temperature while exercising. So yes, aquatic therapy does decrease the pain, as well as it has effect on reducing the spasticity, improving the flexibility of the muscles. And with regards to balance, I would like to say what balance exercises we can do. I just had one slide. There is many things which we can do for the balance training, starting with sitting balance and various functional movements like sitting balance, standing balance. Okay, we can train there are various methods. We challenge the patients with perturbations, and we challenge the patients with reach out activities, or we challenge the patients with say walking in a particular manner, just walking on the marks, or making way through the obstacles. That also trains the balance. Or we challenge the somatosensory aspect. I showed one picture, like we train the balance over the Swiss ball. Okay, so it has a sitting balance enhancement in that way. So it depends on how we are assessing the patient, how do we find the patient in, and then we can give the exercises as per.
So Meruna, can I ask you a personal question? Sometimes in my misguided enthusiasm as a neurologist, dealing with patients with all kinds of neurodegenerative disorders, I often ask my patients to do jumping jacks. Now, both you and Ashish are here. So is this advice correct? Is it wrong? And do you think jumping jacks, simple jumping jacks as an exercise or a combination of core, dexterity, and cardiovascular is a good idea or a bad idea?
Definitely, it can be a good idea if the patient doesn't have any balance challenges. And it is obviously have to consider the fatigue aspect. You have to give adequate rest for the multiple sclerosis patients. So maybe a few bursts of this thing.
Yeah, I sort of agree with that, and I think it's a great exercise, Dr. Desai. But it is, maybe somebody like you who's fit and who does it regularly. But it's actually quite hard to do. It's not an easy thing to do a jumping jack, and obviously do 5, 10, 15, 20 quick successions. Like skipping. Skipping is a very good exercise, but it's hard to do. And obviously balance is an issue or be a little bit wary. So it is a great exercise, but just have to keep in mind that it may be quite taxing for the individual. That's the only thing I would say.
Fair enough.
Yeah, fatigue. Yeah, fatigue has to be done.
Fair enough. Great. We have 2 questions, I think, here about people who experience problems focusing on studies. And Dr. Hattangani spoke to us about cognition, and maybe she can guide some people in the audience on strategies to improve the ability to focus.
Yeah, as I gave some of the tips, you can begin with simple attention building tasks as such, so that, like the letter cancellation task and all those, and taking it to conversation as such, whether the person is oriented to the conversational topic, whether the person is able to hold on to a topic or keep shifting topic. These are something which will help to improve the focus. So we are using language, but we are also working on improving the cognition through language. So, holding on to a topic or guiding the patient back to the topic and saying, but you did not tell me about that aspect of the picture, or you did not, could you also explain this part? You could give a little lead and, help the person to give more information than what was previously given. So this is one of the ways. Storytelling, either, I tell a story as a clinician, I tell a story and ask the person to guess the inference of the story. So how we say the moral of the story, or the, the main message of the story, or what is your take home on it. These are things which again challenge your cognition as such and help you to stay focused. So these would be my suggestions.
Right. In the same way, since you wanted to also share your understanding and knowledge on swallowing strategies, maybe you could, for a few minutes, tell the audience on simple measures you think they could deploy at home to improve their swallowing.
Okay. I'll just like to talk about that swallowing therapy basically is working on 3 or 4 aspects. One is the postures, one is the exercises, one is the maneuvers, and 4th is the consistency. If we work on these 4, I'll just give an example as such. postures, say, suppose, let's say the person is having oral stage dysphagia. So that means the person is unable to masticate because of the poor tongue movements. Maybe mastication is difficult. So I test consistencies. I test in terms of thin liquid, thick liquid, soft solid, and semi-solid and soft solid, and the usual chapati sabzi or that kind of a solid. So suppose I take these in our kit, I have these, or I ask the patient to get different consistencies and I'm giving this. So what I'm checking is how the person is able to tolerate the consistencies. Out of 5 that I tested, how many could he safely have? That is one. Then if the person is not able to have, and I wanted to work on maneuvers as such, suppose the person tends to cough too many times while swallowing. So maybe it is like food is going down the wrong way. The person is not able to guard the airway, and that is why while swallowing his airway is open and the person tends to aspirate. Then I will have something like what is called as a supraglottic swallow. So what I do is I hold a little water in my mouth. Of course, first we teach the technique without the trial feed, and then we introduce the feed. But suppose I have taught that and then I introduce a little water. What I'm supposed to do is hold my breath. So I'm supposed to hold the breath, swallow, and then cough. Why cough? So that if there are any morsels of food or there are droplets still in my throat, instead of going in my airway, I am coughing them out. Similarly, another technique is called Masako Maneuver, where if I want to improve my posterior tongue, the strength of my posterior tongue, what I do is I keep the tip of my tongue between my teeth and then swallow. So if we all try it, you will see that how much effort is required and how much force it is on the posterior part of the tongue, like this. So when I'm swallowing, automatically the posterior part of the tongue, because my tongue is anchored between the teeth, the posterior tongue really has to put in a lot of effort to swallow, and it improves the strength of it. Another is when suppose that's a pharyngeal stage dysphagia, where the upper esophageal sphincter is not opening because of the incoordinated swallow, then one way to do is what is called as a Mendelssohn's maneuver, where what I do is in the normal process of swallowing, where the larynx comes up, the hyolaryngeal elevation goes up, I hold it in that position. So this requires a lot of strength and cognitive ability to understand, but say suppose I hold it and after some time I release it. So in that I'm strengthening my these muscles like this. I don't think you can see it, but what you can do is just observe this. If you can see, my hyolaryngeal elevation has occurred and I'm not relaxing it, waiting for my larynx to, kind of holding it up there. Or I can do passive for a patient who's unable to do it. What I do is ask the person to swallow. And when there is a laryngeal elevation, I hold it in this position for say 5 seconds, 10 seconds, and then I release it. It is strengthening these muscles and helping my upper esophageal sphincter to open. So basically these, or repeat swallow or effortful swallow, they are one. And one of the safest posture if I'm having oropharyngeal dysphagia is if I bear down and I hold my chin tuck in this position where my chin is touching the collarbone. When I do this and I swallow, it kind of helps to pull the hyoid ahead and again give more chance for the hyolaryngeal, for the upper esophageal sphincter to open. So simple things like if I do this, this is helpful. So, and for a person who has just oral phase dysphagia, maybe if I'm drinking water, I try to, take it a little head back posture. But generally for cases with neurological issues, we don't advise the head back posture. The head forward posture or neutral position is the safest. So this is about the posture. So by and by, what we see is the exercises or the oral strengthening exercises, the person has to do less. The postures of right, left, down, head back, the person has to reduce. And consistencies go on increasing. So that is a sign that patient is improving in his swallowing.
Right.
Thank you so much for giving me this.
Great. So there is a question for Dr. Ashish, is that how much exercise would you allow a patient with MS to do? And there are also some questions which are very individual and related to a patient's personal problems of MS, which I think it should be asked to their treating neurologist or physician. I don't think this is the platform to ask those questions.
Yeah.
But certainly there is someone who's asked how much exercise is really allowed. So Ashish, I think you could take this.
Yeah. So just quickly on all those other ones, I saw those questions, knee, heel, etc. Most of those questions that I saw did not seem to have a direct relation with MS. And like anybody can have a knee problem or a heel problem, an MS patient can. So they should, as Dr. Desai said, be addressed separately. In terms of how much exercise, that's a good question. And there's got to be a balance, because if you push the person too much, there's going to be fatigue. And every patient is going to be at a different path in their MS journey. They're also going to be starting with different baselines, because their baseline health and fitness before even they got MS is relevant. So to answer it, I think we normally use something called a rating of exertion, or what we call perceived exertion. In simple language, how hard a person feels they're exercising. So you must, or your patient, or anybody must normally exercise at a level which you consider to be fairly light to somewhat hard. So we say not too easy, not too difficult. You should feel like you're making some effort, but you should not be out of breath that you cannot carry out a conversation. Always start very, very slowly and progress very gradually. Don't be in a hurry to progress. And the human body always is able to respond. At a certain point, you will plateau, and that's fine. But be in constant touch with your doctor and your therapist to find out what that ideal sort of zone is for you. There isn't a fixed amount, but start slow, progress slowly, and go by how you feel your level of exertion.
Okay, very good. I think there is a message from Deepa here saying that I have more questions. Do we have additional time? I'm not really sure how long you want this meeting to go on. It's already 6 o'clock, so
yeah.
I think let MSSI be the arbitrator. I am only a facilitator.
May I ask a couple of questions, since, we're a little late. So my one question, it's related to the heat, that we're having now, the heat wave that is going across in the country. So what are the steps that you suggest from an MS perspective as far as exercise, hydration, and diet is concerned to, take care of, to prevent and avoid any relapse at this time?
Okay, so let me take a stab at it. So I think, where the heat is concerned, one thing I would say is avoid being outdoors, especially in the height of the middle of the day. Now, honestly, today it's even hot, even at night and early in the morning. So I would say during this particular heat wave time, maybe see if you have the ability of walking indoors in a building compound, in your corridor outside your house. And if you are outdoors and you're out working, just keep an eye on hydration as well. Make sure you have some sips of water every 15-20 minutes. Heat also makes your sense of exertion more. So if you ordinarily walk 30 minutes at, say, 4 kilometers per hour, maybe make it 20 minutes at 3.5 kilometers an hour. So reduce your intensity and your time by about 15 to 20%. Food, you don't have to make too many dramatic changes only because of the heat. I don't think that is necessary.
Okay.
Super. I think we've really had a super session today. Lots of very important information, very good speakers. And I think all three speakers have done more than justice to their CVs. And I'm very grateful to the audience for having participated and asked all these questions. And I'm happy to hand the mic back to Mamta. So Mamta, the mic's all yours again. And maybe on behalf of MSSI, you could.
Javed will give the vote of thanks. Javed?
Right. So whoever wants to take on from here.
Yeah, thank you.
Thank you, Dr. Joy. So thank you for attending the webinar on rehabilitation strategy in multiple sclerosis. First of all, I would like to thank Dr. Joy Desai for giving us an insight on multiple sclerosis and facilitating the entire session. Also, I would like to extend a special thanks to Dr. Ashish Contractor, Dr. Meruna Bose, and Dr. Gayatri for giving us insight on rehabilitation strategies. I would like to express our sincere thanks to our founder member, Ms. Sheila Chitnis, for supporting us in the planning the event. I also wish to express my gratitude to our president, Mr. Hemant Nirorkar, and our vice presidents, Dr. Rekha Bhatkande and Ms. Mamta Gupta, for guiding and supporting us during the entire planning process. I would also like to express our sincere thanks to all our respected national office bearers, chapter chairpersons, secretaries, and MSI members, volunteers for attending this program. Thank you, everyone, and have a wonderful evening.
Thank you very much, and thank you, Dr. Joy, for wonderful
Javed,
report.
can we have a screenshot, please, if everyone can come on the screen?
Sure.
Yeah.
I request all of you to switch on your camera so that you could take one snapshot.
Yes, it's on. Right.
Dr. Sheila, your mic is on mute.
Sheila ji,
Mic is mute.
you are on mute.
Sheila ma'am is on mute. Yeah.
So are we done, Javed?
Yes.
Yeah.
Thank you.
Thank you.
Okay, thank you, everyone.
Thank you.
Bye-bye. Have a good weekend.
Bye.
Please send us the pictures. If you could send us the screenshots, it will be nice. Thank you.
Yeah.
Javed,
Bye.
take this.
Thank you, everybody.
Yeah,
Thank you.
sure.
Okay.
Just 1 minute, everyone.
Thank you,
Take this
everyone.
shot.
Bye-bye. Bye-bye. Good night.
Thank you for the opportunity.